Hello, everyone. Good evening, good afternoon, good morning, wherever you are in the world. But we from India are actually at the PCR webinars. This is, of course, you all realize, an educational platform for bringing interactive education to your doorstep. The PCR webinars is a perfect ally for you all. It is ongoing education. We all learn from each other through our peers, key opinion leaders across the world, and you'll get the essential tips to use in your daily practice, your daily PCI practice. Therefore, for PCR webinars, we have 3 webinars outlined over the next few weeks, should we say, or months. And today's webinar is exciting. It's an update in interventional cardiology, trials which influence or change our practice. Of course, in the coming months, you'll have a webinar also on the expanding role of DCB in real-world PCI. And in December, we will have contemporary PCI bifurcation lesions from the bench to cath lab. Next slide, please. So let's update you on the interventional trials of 2025 and 26, I'd say, over the last 1 year, which have changed our practice. Next. So today, we would know about the key clinical trials of PCI over the last 1 year and analyze their conclusions as we put them, not just their conclusions as was presented, but also through our discussions of an expert panel, put them how we apply these trials to our clinical practice. What do they really mean to us? And we want to apply these results, not just understand the results, but also take them to a lab and practice them, perhaps, say, as we get into the lab from Monday onwards. Next, please. And to do this, to achieve our objectives today, myself, of course, is Ashok Seth from New Delhi, India. My colleague, Dr. Dejan Milasinovic from Belgrade, Serbia. And we have Dr. Sengottuvelu from Chennai in India. Next. So this is what we aim to do today. These are the 4 topics and trials related to the 4 topics that we will discuss today. IVUS-guided complex or left main PCI. Is there a benefit from routine use of IVUS? Trials related to this. Calcified lesions, a nemesis for interventional cardiology. Which device is better? Mechanical circulatory support. Should we use it outside cardiogenic shock? And what is its role? And trials related, therefore, to this. And of course, the talk of the town, no webcast can be without the drug-coated balloons. Where do we stand after SELUTION DeNovo trial? So IVUS is going to be presented or discussed, and the trials would be discussed by Dr. Sengottuvelu. Calcified lesion PCI, the trials on that would be discussed by Dr. Milasinovic. I'll discuss the mechanical circulatory support trials of the recent past few months. And of course, there's the drug-coated balloon, which Dr. Milasinovic will discuss. So let's move over to the first set of trials to address the first point. Next, please. And Dr. Sengottuvelu, please take over and discuss the recent trials.
Good evening, all of you. I think we're going to talk about 2 important trials, Optimal and the IVUS chip trials, which is really given a sensational results with many of us really want to learn from this. We know we are routinely using IVUS for left main PCI, and the guidelines are still recommending it. But the European population, there is positive data, and hence this trial was done, whether routine IVUS-guided PCI improves outcomes over angiographic PCI in unprotected left main PCI. That was a question which was answered. Next slide, please. Okay, so this is an investigator-initiated trial. It was an international trial involving about 28 European sites. And this was labeled as a superiority randomized control trial for 806 patients. So 1:1 randomization was IVUS versus angiographic guidance. The median follow-up was 2.9 years. So these patients' mean age was 71, and the syntax score was 30, which means a little complex lesions. And the IVUS, pre-procedural IVUS was optional, whereas post-procedural IVUS was mandatory. And they still had the targets, the MSA targets of the old targets, which is 5, 6, 7, 8. So the angiography was guidance did not use IVUS, and only if it is really necessary. So the primary endpoint was a composite endpoint of all-cause death, stroke, MI, and any repeat revascularization. Next slide. So the results were quite surprising. What they showed was there was no statistically significant difference between the IVUS and angiography arm. And in fact, numerically, there were higher rates, higher events in patients who had IVUS. And this was quite surprising, and we need to understand why this could have been happened. And again, it was seen that after the post-procedural IVUS, it changed management only in 29.3%, nearly 30%. So majority didn't act even after seeing the post-procedural IVUS. And we were also surprised to see an increased stroke signal in patients who had IVUS. Again, this was a late stroke, a median of 19 months following procedure. It's very unlikely that IVUS, intra-procedural IVUS could have caused a stroke later after 19 months, which is very unlikely. This is probably by chance, which we cannot explain. Next slide. So what does it mean for practice? Though this trial didn't show any outcome in both the IVUS and arms, but how do we explain this? Probably those operators, European operators, were highly experienced, and when the angiographical arm was done by the same operators who had good experience, and hence they were able to achieve very good results without the IVUS. Possibly that could be one reason. And again, we know, as I mentioned, the pre-procedural IVUS is only done in about 30% of the patients. And most of these patients, even though it was left main, the majority were single stent crossover. So it was not a complex subset of left main involving 2 stents. And the stroke cannot be explained. So this is the trial. Also, we know that by looking at the angio, we cannot see any ostial miss or stent distortion or stent under-expansion. So really, angiography has limitations. So let's talk about the next trial. Next slide, please. So I'm going to talk about another trial, then we'll have a discussion. So this is another trial, again, a European trial, which is IVUS CHIP trial, almost giving a similar result. But again, this is a subset of complex patients, complex coronary heart disease. And why they did the trial? Because again, the European guidelines recommend IVUS for imaging for every complex PCI, whereas in practice, they do it rarely. And hence, they want to get some European data. So the question what they wanted to answer is, does IVUS-guided PCI for complex coronary heart disease improve outcomes compared to angiography alone in a European population? Next slide. So this was again an investigator-initiated multi-center trial involving 2,020 patients in 37 European centers involving 7 countries. They had a median follow-up of 19 months. Majority of the patients were NSTEMI or patients who had coronary disease, acute coronary syndrome or stable patients. Then the defined complex CAD of all these severe calcium, CTOs, bifurcation, ostial lesion or lesion length more than 28. Again, it is important to note that majority of these patients in the trial were only less complex. I'll come to it later. So it was not really complex as mentioned in this selected criteria. So in this arm, 1,110 patients were IVUS guided. The remaining 1,010 were angiographic guided. And the criteria for IVUS, they had a predefined criteria. We said MSA less than 5 millimeter square, edge dissection more than 3, and plaque burden less than 50%. Again, the primary endpoint was target vessel failure, cardiac death, target vessel MI, and TBR. Next slide. So again, this trial was a negative trial, again, which you can see that this trial had the hazard ratio was 1.25 with a very wide confidence interval of 0.97 to 1.60 with p-value of 0.08. What it means is this trial cannot be really inferred either it is a positive or a negative trial. And how do we explain this numerically higher events in patients who had IVUS? Again, this is probably by chance because IVUS cannot give higher events like target vessel failure just by doing IVUS. And again, they also seen that the stent thrombosis rate was better in the IVUS arm. That is one thing which is favorable for this trial, even though it was very modest, but it had definite advantage in terms of reduction in stent thrombosis. The other important feature in this trial, the complexity, the majority of the patients who were complex lesions were only length more than 28 millimeter, which means The complexity factor of the rest of the complexity factor not taken into account. Majority were just long lens, which really doesn't mean a complex population. And second, the severe calcification was seen in 44, but all were assessed using angiography. So again, we don't know really how clearly it was a complex lesion. Next slide. So what we should do in this trial, again, we know that though IVUS really don't show any high signal of any harm, but again, it showed only a slight benefit in terms of stent thrombosis. But we know that this trial cannot be really applied in practice, considering that the complexity was really diluted. And again, this was done in a European population, and though they were all experienced operators, we cannot put this into practice. Similar to a trial like Illumin 4, which didn't show real benefit in terms of hard endpoints of death or mortality benefit. So I think with this two trials, both IVUS chip and one optimal trial, showing there is no benefit with IVUS, how should we really apply this in practice, Dr. Seth and Dr. Dejan?
Very interesting. Really very interesting. Dejan, what's your take on this? After all that we've had in terms of guidelines for imaging, especially for left brain, and the fact that imaging is now class 1, where do you fit these trials into clinical practice?
It's actually very interesting results, and I think there are 3 points that we need to take with care when interpreting this. Number 1 is, what were we trying to achieve? We were trying to achieve better outcomes by utilizing the benefits of IVUS. As Dr. Sengottuvelu nicely showed, those benefits were not uniformly defined. So in the optimal trial, for example, you used IVUS in only 65% of the patients to plan the procedure. So you did not use it in all the patients. And if you say if IVUS is used in every patient to plan the procedure, this might have provided more benefit. So that's number 1. How IVUS is used is still not standardized. There is a very nice paper from Dr. De La Torre Hernandez several years back, published in Neurointervention, that using a standardized IVUS protocol will produce benefit over using IVUS in a random manner. So the question is whether, for example, in the optimal trial, we did have a standardized protocol which would have a clearly predefined set of goals going into the procedure and finishing the procedure. Number 2 is the notion of the biological limit, the notion of a biological ceiling. IVUS is a diagnostic tool. So if you use IVUS to show that there is a very diffuse disease, it can be that despite using IVUS, you will not be able to perform optimal stenting, just for the fact that there is no good landing zone. Or if the calcium is too dense, using IVUS will tell you there is calcium, but it will not help you deal with a very dense calcium. So there is a biological limit to what we can do based on what we see on IVUS. IVUS by itself is not therapeutic, it's diagnostic. It can show us a problem, but maybe we do not have a solution for every biological problem in terms of atherosclerotic disease. And the final point, number 3, it's the difference in the Western and Asian trials. And there is also a difference in the global use, which with much more IVUS and intracoronary imaging being used in East Asian countries, which also means that the milieu, the environment for the trials is different. So if you have very experienced European IVUS users randomizing to angio and IVUS, it is probably likely that they will do a good job based on angio alone because they already have had vast IVUS experience as well. So those are the 3 points I think which need to be taken into consideration. But the big question is, Dr. Seth, and you are by far the more experienced one here, will this change our practice? Will these 2 trials change our practice today?
Probably not. And I think I want to emphasize 2 important points as far as optimal is concerned, as well as IVUS chip. Look at optimal. A crossover stent in 65% expert operators, this cannot be generalized to real-world practice. And I think these are expert operators who were trying to do a good job without imaging because they knew that it was an open label study, by the way. And therefore, they were clear that they wanted to do a good job, even if it is angiogram. So they actually learned from the experiences of IVUS and extrapolated into what we call angiographic optimization, which was really IVUS trained in themselves. That's the reason why we can't extrapolate it to the real world, because IVUS is essential for everyone to achieve optimal results much earlier on in the career. And it's only on the simpler cases, then you can say, but I think perhaps I'm so experienced that I may be able to perhaps do this without it. But I'd say that's why it won't change our practice. We have those defined goals. We want to achieve them. And by the way, this happened at a trial, but even expert operators sometimes get fooled and misled by what angiography shows or does not show. And there's a lot it doesn't show. We learned that even from October trial, that there's a lot angiography doesn't show, for which we really have stent deformation, have 20% stent deformation, as was seen in October. So we want to keep that in mind. And I also want to therefore emphasize the fact that this happened again in IVUS chip. What happened in IVUS chip? If majority of the lesions are, all that's complex about them is a 28 millimeter long lesion, then that's really not complex lesions. Really, when you talk about complex lesion subsets, you talk about heavily calcified bifurcations, we're talking about CTOs, we're talking about loads of both analytical lesions, where we are quite clear that without IVUS, we may not even get an optimized result. So I think, as such, it's certainly not changing our practice. Interesting and well done trials, but perhaps not really practice changing as far as I'm concerned, because these are not the lesions. All it says is, maybe in experienced hands, IVUS is not for all lesion subsets, but it's still there for very complex, and in less experienced, they must use IVUS for even left mains and all complex lesions.
Absolutely. So there's a question which asks whether if we use the old criteria of 5, 6, 7, 8. Absolutely. They didn't use the larger criteria. And more importantly, if you look at the latest, same time in the TCT, they also showed the DK Crush 8 trial, where they showed that patients who met the criteria had better results. Again, in this patient's group in optimal, they didn't react. Only 30% of the patients, they reacted after the final IVUS, which means that whether they achieved the criteria is not known. They had a pre-specified criteria was late, but it was not whether we don't know whether they fully achieved that. So that is why in the DK Crush 8, wherever they found the optimal criteria was achieved, they showed huge benefit of the IVUS. So as you said, I think we should not take this into consideration, considering the huge data with large meta-analysis showing benefits with IVUS. I think we need to use the best options available for our patients to give the best possible outcomes.
And finally, longer follow-up is always very important. And much of this, we've seen that at 3 and 5 year follow-ups, some of the data from Korea, which shows it's a 5-year follow-up where you see the differences emerging out of IVUS guidance. So I think 3 and 5 year follow-ups are also important. So yeah, I think we've discussed this enough and put it into perspective. If there are questions, we can address it, but we certainly need to move on to the next. Do you see any questions coming through?
Yeah, I just wanna reiterate maybe before we move on, a final sentence that actually Dr. Seth said, but for me, that's the best conclusion to this part. We have 2 new trials which are neutral, and I think my conclusion is, as Dr. Seth said, in experienced hands, these trials combined showed that IVUS or intracoronary imaging in experienced hands does not have to be a routine for every lesion. As Dr. Sengottuvelu said, in the optimal, there was not a lot of 2-stent bifurcation PCI, which may be a lesion subset requiring imaging more than a single stent procedure. So I think experienced hands, not really a routine for every lesion. That is my take from these two trials from this year. But there will be new trials coming on. So I'm excited how this field will move forward with intracoronary imaging. I think all three of us will keep doing intracoronary imaging as much as we can, especially in complex lesion subsets.
Right. Oh, that's a great summation. And let's move on to the next topic. And so the next set of trials.
Next slide, please. Yeah, so the next set of trials is about calcified lesion PCI. And I think one of the most common asked questions here is, since we have many devices, which device is better? So which device should be used for a severely calcified lesion? And the next slide will show you the first of the trials. Next, please. I've prepared actually 3 trials which have been presented at TCT 2025 and EuroPCR 2026. Those 3 trials were comparing different specialty devices for calcified lesions. And I will walk you through these 3 trials. Trial number 1, shortcut, TCT 2025, cutting balloon versus intravascular lithotripsy. You see here that there were 2 cohorts, one with planned rotational atherectomy, the other without planned rotational atherectomy. And you see the MSAs, which were the primary endpoint. Now, overall, non-inferiority for cutting balloon versus IVL was met because there was a difference of 0.6 millimeters squared, 8.0 versus 8.6. Now, if you look into the different cohorts, the difference after atherectomy was negligible. They virtually had the same MSAs. As opposed to that, in patients without previous atherectomy, there seemed to be a difference with a less MSA with a cutting balloon. Now, that's exploratory because the non-inferiority was designed for the whole trial. But it was interesting to see that, as you can appreciate from this slide as well. There was no difference in terms of the number of fractures. There was no difference in the stent expansion. And there was also no difference in minimum stent expansion. Costs were less with cutting balloons. And I think that is an important point as well. So the question whether cutting is better than IVL is, I think, difficult to answer with this study. There seems not to have been a large difference looking at the MSA, minimal stent area. So if we go to the next slide, which is the next trial, also at TCT, Victory trial, high pressure balloons versus IVL. Again, we see no difference in the MSA, no difference in stent expansion. Now, what was of interest to me here was what happened with perforations. If you ask me, if you want to compare high pressure balloons with IVL, I would have said that IVL is safer, quite honestly. I would have said, with high pressure, you may risk perforations, and I don't want that in calcified lesions. However, within this trial, Victory trial, there was no difference in perforations, but intracoronary imaging was used for the sizing of the balloons. That is very important because if you miss the sizing and if you go to inflate the super high pressure balloons, you may risk the perforation more, I think, than with IVL. So I think sizing is the key factor here, and sizing was based on intracoronary imaging. Just one more important fact regarding the previous trial, the shortcut trial. The way that the cutting balloon was used was sizing it 0.5 millimeters below the reference and inflating it to 16 or 18 atmospheres. That was how cutting was used in the shortcut study, which showed its non-inferiority as compared with IVL, especially post-atherectomy. So the combination of atherectomy and cutting seems to work nicely, or as nice as atherectomy and IVL. Next slide. And this is the final third trial with basically the same setup. 2 devices being basically compared. Here, rotational atherectomy versus IVL, the iCare trial, iCare OFDI trial, presented just a month ago at EuroPCR 2026. And you can once again see the primary endpoint here in a rectangle to the right of the slide. Minimal stent area, again, very similar, 6 millimeters squared. So you look at 3 trials where IVL was compared to cutting, atherectomy, rotational atherectomy, and super high pressure balloons. And all 3 trials were basically showing more or less the similar MSAs. So to me, the larger problem is what is marked here in red. If you look at red, that is the proportion of patients in both study arms which had an MSA less than 4 millimeters squared on OCT, on OFDI. Less than 4 millimeters squared is not what we wish. And it was 20% of the patients, no matter which device you use. So to me, the biggest take from these 3 trials is not that there is a difference among the devices, but the way we use device is very important. Which device for which lesion is, I think, the true question. And also, how do we address those 20% of patients which, despite the use of devices, still do not achieve the expansion we want? Next is the last slide in this part, and this is only an information because this is not really a trial. It's an ID trial, an ID study, which was partially conducted in Europe as well. Presented this year, just a month ago, in Paris at EuroPCR 2026. But to me, an interesting point, which I think needs to be discussed, and that is a next generation or a different IVL balloon, a different IVL device, a seismic device, which, unlike the IVL which we have used so far, has a 360 degrees ultrasound pulses. So basically, the one that we have been using so far is 180 degrees, and this new device has basically 4 emitters and can emit 360 degrees around. This could be of interest, especially in eccentric calcium. Now, the IDs study has gone well so far. We've seen the presentation at EuroPCR, but it is, of course, not a comparative study, so you cannot really learn much how it compares to other devices. But it's interesting that the delivery was fine. What I would think is that the delivery would be more difficult if you have more emitters. But I guess time will tell how it works. But it's an interesting concept, and I would like to bring it up here. So what do you say about this, Dr. Seth, Dr. Sengottuvelu? What's new for the calcium?
So I'm very, the shortcut study. Let me just comment on the shortcut. It's I'm not a huge fan of cutting balloons in severely calcified lesions. And we must point out the deficiencies of the shortcut study. We well realize that IVL is a very effective tool for severely calcified lesions. And if you take into account the fact that one looked at the MSA, which is a surrogate endpoint, and only a 30-day follow-up, you do realize that the surrogate endpoint at 30 days may mean nothing compared to the real issues around stent thrombosis, death, MI, etc., which are all 1 year, 2 year, 3-year follow-up. So this short follow-up has its own deficiencies. The second important aspect of the study is that 50% of the lesions have been rotablated and then enrolled. Then I'm not sure what we're seeing around the benefits of cutting balloon versus an IVL. I think that's a big deficiency out there. The ability to cross the lesion and then randomize it to one or the other is again a deficiency itself. It practically means that many of the real heavily calcified lesions, which truly separates these two devices out, were really not the lesions of the real world, heavily, severely calcified lesions. And therefore, this trial perhaps relates to moderately calcified lesions and IVUS guidance, where perhaps both devices, if IVUS guided, could give the same outcomes, but it's really not the technology which did that. It was IVUS-guided. It was the fact that it was moderately calcified lesions, and the fact that it was surrogate endpoints and a shorter follow-up. So for severely real-world, heavily calcified lesions, as identified by imaging, I do not believe that a cutting balloon can equate IVL, but that's the impression I get from the study. Sengo, over to you for the remaining part of the discussion.
Regarding the Victory trial, there has a single endpoint of stent expansion, and we don't know how severe the calcium was. We don't know how whether they had nodules and all that. We don't know. Actually, comparing IVL and the OPN balloon and saying that it was IVL, the OPN was non-inferior. That was the end result of the study. But the calcium, clearly the quantification and the severity of the calcium was not at all established in this trial. So though the clear endpoint of stent expansion was adequate, we cannot generalize that an OPN balloon can do the same as IVL balloon. We know that IVL gives a very controlled, safer calcium fractures, unlike an OPN balloon. Although this trial didn't show increased complication, but we know that it can cause a higher risk for it's like a crude dissection, which can create more issues. So I don't think this is applicable to consider IVL as equal to OPN as equal to IVL, and we should not generalize it. And probably maybe we should study the imaging, understand the procedure, the calcium morphology and characteristics, and then decide. And maybe one can even use a balloon. And if the balloon opens up, fine. Otherwise, you can go with the IVL if the cost is an issue.
And Dejan, I would just want to address another point. Both these trials actually demonstrate the important use of intravascular imaging to achieve MSS. And I think that is the crux point that I want to emphasize. The fact that MSAs were big, the fact that in both groups the MSAs got to an equal level, is not because the devices achieved that, is because through use of IVUS. And by the way, both devices would then need post-dilatation, which is practically done in close to 95% of these patients were done, was the reflection of the IVUS use rather than the device themselves. That's what I was saying.
Next slide, please, maybe, because I want to just make maybe a general comment, because I tend to agree with what you said. So we were here at calcified lesions, and the question was which device is better. And I am not sure that's the right questions, quite frankly. I think going forward, the right question will be which device or which combination of devices for a given calcium type.
Yeah.
That I think will be the real question for us. Absolutely. Because, you know, it's not this. If you have a concentric calcium which is thick, I am not sure cutting will do the work there. I think you will need pulses like we have with intravascular lithotripsy, whichever device will be available. And if you have a thin calcium, then maybe cutting is enough and you reduce costs. And then if you have eccentric calcium, using a 180 degrees emitter system may not be enough in eccentric calcium, and maybe using a 360 degrees in the future could be better. So I think the right question, I think, at this point is not which device is better, which I think was the core question asked by the researchers over those studies that we presented this year, but more which calcifying lesion type necessitates which device or combination of devices. Because as Dr. Seth rightly pointed out, if you randomized after you already secured crossing the lesion with a balloon, then you exclude already a proportion of patients which you can never cross without atherectomy. So a combination of devices, multi-device approach, I think should not be ruled out in the future as well. And we should not ask the question which single device we should use, but rather which combination of devices or which device for which lesion. So that to me would be sort of a conclusion from this point.
Right. So now we move to the mechanical circulatory support. And of course, we're talking about mechanical circulatory support, not in cardiogenic shock, but for protective PCI, maybe we're talking about acute MI. as well. So let's have the next slide, please. Those are my conflicts. Next slide, please. So these were the two trials, and very important trials, presented at the ACC and published in the New England Journal of Medicine. Let me get you to the first trial. The first trial is the SHIP Pieces 3, a very important study of left ventricular unloading in high-risk PCI. Next slide. So what's this about? We well understand that protected PCI, a supported PCI, rapidly increased since FDA approval in 2015, and its expansion in 2018 expanded to less severe low ejection fractions, or moderately low ejection fractions rather than severely impaired LVs. And by the way, very less of little randomized evidence. But we all realize that microaxial flow pump, which is what supported or protected PCI is all about, Impella, has its own trade-offs, bleeding, vascular problems, and of course, those are vascular access problems and cost. So next, the real question was, and needed to be answered. Could we go to the next slide, please? Whether percutaneous LV unloading using the microaxial flow pump, which was Impella CP, reduces death and major adverse cardiac events versus PCI without planned circulatory support in patients with severe LV dysfunction undergoing complex PCI. A very simple question where intuitively we've been using Impella without any evidence. So this was an open label study, a randomized controlled open label trial, 1:1 randomization, 300 patients at 21 UK hospitals with ejection fractions less than 35% or less than 45% in those who had mitral regurgitation, with severe mitral regurgitation. They had a BSIS jeopardy score of greater than 8. 0 to 12 is the score. The higher the score, the worse is the complexity of the patient. And of course, these were complex PCI. And of course, this was a hierarchical composite primary outcome using the win ratio. And that's well described over a 12-month period. And the median was, by the way, a 22-month follower. So the mean ejection fraction was 27%. The jeopardy score of this population was highest at 12. The Cinta score was 38. And that's pretty complex patients. The Impella group had 98% of the patients had a successful implant of the Impella. Let's get to the results. Next slide, please. And those are the results. No reduction in primary composite endpoints. In fact, on the other hand, a signal of harm with Impella CP. The primary outcome win ratio was 0.85, which was in favor of the controls, the standard of care, and not the Impella. Death from any cause was 32.6% in the Impella CP group, the microaxial pump, versus 23.4% versus standard of care, which was no Impella, no mechanical circulatory support. And cardiovascular deaths, you see, again, in favor of the standard of care, higher with Impella. And look at other secondary endpoints. Periprocedural MI, again, higher with Impella group, spontaneous MI, high, disabling strokes, equal cardiovascular hospitalization, and no. What's interesting, next slide, please. What is interesting was certainly one aspect, which was Impella CP did not actually show high bleeding risk. So here's the conclusion. The routine use of microaxial flow pump did not reduce major adverse clinical outcomes in patients with severe LV dysfunction undergoing complex PCI, which is protected PCI. And there was an excess of death due to cardiovascular causes in the patients who received PCI with a microaxial flow pump. Interesting observations after what we thought was an intuitive decision to use microaxial flow pumps for every impaired LV fraction going with high-risk lesions undergoing PCI. Now, let's move on to the next one, and maybe we should discuss both together. The next slide, please. Again, at the ACC is this study. And the study is left ventricular unloading in STEMI without cardiogenic shock, the STEMI door to unload trial, which was presented at the ACC, published in JACC. Next slide, please. And this is based on the hypothesis. In fact, it's been shown in preclinical animals. We all realize that infarct size predicts outcomes. And in animals, unloading of the left ventricle using impeller for 30 minutes prior to reperfusion nearly decreased the infarct size by half. And that's what's very interesting. And this is why therefore this preclinical data was then put into trial. And of course, there was a pilot study on this as well prior to this large trial. The trial asked an important question: whether unloading plus a 30-minute delay before PCI is superior to immediate PCI alone in decreasing infarct size, i.e., patient comes in, we first put in an impeller, unload the heart for 30 minutes, and then do a primary PCI versus immediate primary PCI. The design, open label randomized control trial, 1:1 at 55 sites in 6 countries. These were anterior STEMIs without shock, but large anterior STEMIs, 1 to 6 hours from onset. The primary endpoint was infarct size as judged by CMR on grade 3 to 5. 265 patients in each arm. So a total of 520 patients allocated. And look at this bottom line here. 165 minutes was the door to balloon time in those who had the standard of care, which is immediate PCI and opening up the artery, versus an addition of 47 minutes, leading to a 212 minutes in those who had impeller unloading for a 30-minute prior to PCI. So this is how it all went. Next slide, please. So there was a delay of 47 minutes in opening up the artery. Next slide, please. And this is what the results. The infarct size was unchanged. No difference in unloading versus immediate PCI. Next slide, please. In fact, we were probably doing more harm in inserting impellers. Bleeding and vascular injury was high in the impeller arm, understandably. And this was totally device related and access site related. So there was no benefit, but actually a harm. Next slide, please. So this confirms the mandate. Do not intentionally delay reperfusion in STEMI without shock. No role for routine pump. First unloading in anterior STEMI without shock. And door to balloon time stays paramount. Door to balloon, door to reperfusion time is what we say, stays paramount. And ischemic time tracks infarct size. And let's make sure that we give our patients the best for anterior STEMI without shock, reperfusion without delay. Still is the bottom line, and we do not need to place and unload the heart prior to PCI. So we now open this for discussion, and where does it fit into our practice? Especially, let's look at the BCIS chip 3, and of course, unloading. Sengu, what do you make of the BCIS chip 3?
Yeah, these are very interesting trials. I think we started using it very prematurely before we have much evidence, even though the PROTECT trial was stopped prematurely, PROTECT 2 trial. So are we really started early? I don't know, but this trial is really changing our practice. And the other important thing is this trial was not funded by industry. That's again an important trial compared to the protected trial, PROTECT PCI trials. So Probably, I think this is. I think we should still reserve those plumps for extreme high-risk cases where we have hemodynamic instability. And I know it's very difficult to predict which patient is going to become hemodynamically unstable. But I think one thing is clear: for complex PCI, protected PCI, I don't think we should really consider using routine impella from this trial.
Dejan?
Yeah, I have to be very provocative. So I have to ask two provocative questions, because I
happy to answer them.
Look at it. Yeah, I want to look at it as a whole. Number one, is mechanical circulatory support in clinically stable patients undergoing complex PCI a relief for the operator, or is it a relief for the patient? That's the number one. And the number two, question number two, what is the future of mechanical circulatory support outside of cardiogenic shock? I think in cardiogenic shock, given the data we have, which is one randomized trial, but it's a good signal from a one randomized trial that it can save lives in a well-selected population of patients, and I think that's a good signal. What about outside of it? What do you see as an experienced MCS user is the future outside of cardiogenic shock? So two questions.
So for the first questions, what this trial pointed out is that routine use of patients with just low ejection fraction, less than 35%, and the mean ejection fraction 27%. And yes, there was lesion complexity, but routine use could be replaced very easily by systematic contemporary PCI. By the way, in this study, imaging was highly encouraged. Contemporary PCI was encouraged. Even staging, if needed, was encouraged. And there were patients who were staged preemptively by defining staging and saying we would actually stage the procedure. And that's what it showed. It certainly doesn't take into account those patients who can be selected and the why. And I say that because in India, we have neither shock, and we don't necessarily use it for routine, stable patients with normal PA pressures just because we're doing complex lesions, because we can stage them. But our patients who undergo are neither in shock, but they have had heart failure, they had raised PA pressures, they've been brought out of heart failure, they've got low PSATs, they're borderline pressures, and yet are not into shock, which is stage C. But we're doing complex PCIs on what would be stage B, who are extremely high risk of decompensation because they have raised PA pressures and low PSATs. So I think there is a group of patients in India where we, because of the fact that it is an expensive device and we know who are going to actually benefit from it, do it. But where the West went wrong was using it even on any complex lesion subsets who were stable, even with normal PA pressures and normal EDPs and normal cardiac indexes, just because they had complex lesion subsets. So that's the first point. Yes, it was more for the operator than for the patient. And the second point that I'd like to make is, did you see the fact that there was absolutely no excess of access size complications in the Impella group? While in danger shock, that was high. The reason was that in BCIS CHIP study, they mandated vascular access by ultrasound and an assessment, an appropriate assessment, because this was elective. And therefore, now think of it if it was put into routine use across and said, Impella is a great tool for these were experienced centers with mandated access, vascular access assessments. Impella is associated with clearly higher risk of vascular access problems. And therefore, BCIS results could look even worse if really it was just all centers defining it for this use. So I'm happy that BCIS actually showed that routine use is unnecessary and is fraught with its own problems. I'm absolutely happy that we now are in favor of even staged PCI in many of such patients. But yes, remember, it says routine use. It's still out there. for selected use, and we should therefore weigh our options and our patients very systematically with their hemodynamics, even though they may not be in shock, with their hemodynamics, to actually predict and define those who need it.
So I just have one final question to you. So with all this trial, would Dr. Seth, would you still continue to use in some situations, or is it Impella gone for protected PCI? I know we will use it for cardiogenic shock, but for protected PCI.
I just defined that. In fact, majority of the patients we use it on do not actually fit into the BCIS chip. The ones we use it on are the guys who've had MIs, who are not in shock, but who've been in heart failure, who've got extensive disease, with surgical turndowns, and still have elevated EDPs and raised PA pressures. Perfect. Those were not the patients who were included. These were very elective patients.
I think this is an important point.
And they are a cross between cardiogenic shock stage C, which they aren't, but they are stage B definitely.
So
or decompensated heart failures.
So because sometimes in the news, when you hear about new trials, similar to IVUS, as to Impella or MCS, you may be overshadowed by the news of negativity. But when you dive deeper into it, you then can distill more rationally about the results. So for IVUS, we said we are, of course, going to keep using it. And for the MCS, you just said, there might be a subset of non-cardiogenic shock patients where you still would see a benefit. And I think you nicely define it. Elevated LVDP is, I think, an important variable here. So maybe we go to the last topic due to the time.
Yes.
Next slide, please. So this is about the drug-coated balloons. There will be an entire webinar dedicated to drug-coated balloons where you will see the practical and discuss practical points with cases. This is to speak about SELUTION DeNovo briefly, and I think we will be speaking about this trial more and more over the year to come. So next slide, please. The first results, the primary results, were presented at TCT. And there it was announced that the non-inferiority was met, that the DCB strategy was non-inferior to DES strategy. Now, what did DCB strategy mean? It meant we go primary with the DCB and convert to DES only if we have to, because of a flow-limiting dissection or acute recoil. Most likely. And 20% of the patients did need a DES within the DEB strategy. And you see that the non-inferiority margin was not crossed, but it was close to it. We do not have more time today to discuss what happened further. At CRT, per protocol, non-inferiority was not shown. Now, the difference between intention to treat and per protocol exists. And I think there will be time and more space to discuss this. What I would like to point on the next slide is the importance of the understanding of the study design. So here you see highlighted three very important points. Number one, this was not an all-comer study. STEMI, CTO, left main were excluded. Number two, this was not a device trial. It was a strategy trial, which meant that if you say that you want to be conservative on the non-inferiority assessment, and by that we mean that you want to have non-inferiority both at intention to treat and per protocol analysis, because you want to be stringent on the device, you cannot really make this argument on this study, because this study was a strategy trial, not a device trial. So you can be conservative on the DEB strategy, and you need to explore what was the DEB strategy in this particular trial. What was the threshold to use stents in the DEB arm, but also what was the threshold to use DEB in the DES arm? Because if you use DEB in the DES arm, in the stent arm, in those cases where you feared stent failure, then you basically excluded those patients with potential events from the per protocol analysis. And I think this needs to be understood also better. The manuscript is out, and I look forward to it. If you ask me what my take is based on those primary outcomes, I would say two things. Safety seems to be proven because we do not have an excess in death or periprocedural MI with the DEB strategy. And this confirms the prior results of the cage-free trial, which is a large Chinese trial in large vessels as well. Be mindful, SELUTION DeNovo and REC cage-free trials are the only trials including vessel diameters above 3 millimeters. All the previous trials included vessel diameters less than 3 millimeters. Number two, target lesion revascularizations. So the need for a new revascularization seems to be slightly more frequent with DEB. And this coincides with the cage-free results as well. Those are 2 points which I think are important to be taken. Number one, DEB seems to be safe. Number two, in large vessels, what we may risk is an excess in TVR. We don't know that yet because, as you can see here in red, and that's the third point, there is a 5-year analysis planned, which also will be a superiority testing if non-inferiority is reestablished. We do have intention to treat non-inferiority already at 1 year. If this is shown again at 5 years, there will be a superiority testing between the DEB strategy and the DS strategy. Finally, next slide. At EuroPCR this year, 2026, there was a sub-analysis of SELUTION DeNovo, interestingly showing a tendency towards better results of drug-eluting balloon strategy as opposed to stents in complex lesions. Now, that is very interesting. If in those lesions where stents are associated with a higher likelihood of failure, DEBs could be used as a strategy to reduce stent-related events or the occurrence of those events. That is, of course, potentially very interesting. This is only a preliminary presentation at EuroPCR 2026. We will see it in more details once it comes out as a full paper. But for now, I think SELUTION DeNovo brings us, and I will conclude with these 2 important points. Number one, DEBs seem to be safe in large vessels. Number two, we need to understand better whether TVR or TLR is more frequent, and if yes, why and in which lesion subsets.
Okay, so
Thank you, Dejan. I'll also add to it. It brings out one other important point, and that's perhaps is the largest randomized trial of a sirolimus-eluting drug-coated balloon, and for the first time showing that sirolimus-coated balloon may work. But I will also want to point out, did you realize that this manuscript got published, I think, last week? There was another conclusion added on, and I think that's another point for discussion. The conclusion, and this is, of course, got published last week, and it also said, and I read out the conclusion, which is relevant. At 1 year, the primary intention to treat analysis population, which is what was presented at the TCT, a strategy of PCI with sirolimus-eluting balloon and provisional DS was non-inferior to systematic use of DES for the primary endpoint of target vessel failure. But the per protocol population sensitivity analysis did not confirm non-inferiority.
Okay. Can I take that? Yeah.
Yes, please do.
So if you look at per protocol, what they take into account is they take only the pure DCB patients who only had DCB without the patients who had a bailout stent, just only the DCB versus the patient who had the stents. Okay, here practically what we do in our case is sometimes we need to put a bailout stent. We see there is a dissection or a recoil and we put a bailout stent. When you take the entire population with intention to treat, that is the patients who had a 20% crossover, which means 20%, this little high in this study, which 20% of the patients had to crossover the DCB arm, then they had to treat with the additional stent. So if you take those patients, including the patients who had stents, 20% of the patients with stents and the 80% DCB, that is intention to treat, there was a non-inferiority shown in this trial. So practically, in practical use, what my take home is, we generally use DCB, and some situations we need to cross over to a stent. And this strategy has really shown a benefit in terms of non-inferiority, and it has shown a lot of safety signals. And in fact, they are looking for superiority at 5 years. This again, as we will know over time, we know that the stents have every 2% failure rates every year. So looking at that, my practical what take home from this trial is, I would really be more encouraged to do DCB even in large vessels like in this population.
Hello.
So my question to you, if I may, Dr. Seth and Dr. Sengottuvelu, is SELUTION DeNovo trial encouraging the use of DEB? I certainly do not think that it encourages replacement of stents by DEBs, but does it seem to encourage using DEBs more than we used to?
I certainly
What is
feel
your
that
take?
my take, it certainly encourages us to use DEBs more. And I think one of the important points here which comes out is, I still wouldn't think it was just using it in, I would say, yeah, these were vessels which are 3 millimeters, 3.1 was the mean vessel size. 28 millimeter lesion length was the mean lesion length. But I would say, I'll just be more cautious around this. I'd say it encourages us to use DEB more. That's very clear. I'm also encouraged by the fact that it also tells us that the concern about acute occlusions from DCP is clearly unfounded in a present era of contemporary PCI and contemporary antiplatelet therapy. So that's the second point, which is a big concern always. And finally, I still worry about the fact that non-inferiority was not met. And I would say it's fine that you say the strategy of bailout, but you cannot hit the nail on the head so clean and clearly that you always have a strategy of a bailout all defined. For you, the bailout strategy may be 20%, or for somebody else, it may be 3% and leave things alone. For someone else, it may be 50%. But what worries me is the fact that it did not meet non-inferiority in those who were assigned to DEB alone at the end of 1 year. What does that mean? It's still not as good as stents in large vessels. As a strategy, if you refine your bailout strategy, you would get away with it. And yes, in 80%, you won't then put in stents. But if you did not know which patients you can get away with and said, okay, fine, this was great DEB, your results would still be inferior to a drug-eluting stent.
Yeah, the risk of TVR seems to be a bit higher. And I think this is what explains what explains this tendency that we also see in the per-protocol analysis. Maybe the final slide, if you can, just so, because I think we are nearing. Can you move to the next slide, please? Because this is sort of a conclusion. So may I ask the two of you I would be eager to, what are your answers to those questions? The 4 questions we have.
Okay.
Dr. Seth, Dr. Sengottuvelu.
Okay. IVUS-guided complex left-main PCI. Is there a benefit of routine IVUS? Although both optimal trial and SHIP PCI trials, SHIP IVUS SHIP trial showed neutrality, but looking at the overall evidence and strong meta-analysis data favoring IVUS, I will still consider IVUS particularly for complex PCI. Yes. And left main.
Next question.
For calcified lesions, PCI, clearly for severely calcified lesions, imaging defines for us which device for which lesion. For me, it's the comparisons presently do not matter in device synergy. And for the most of the real world heavily calcified lesion we end up dealing with in our contemporary real world present day practice, sometimes it's device synergy rather than a device alone. So I think much of these trials were superfluous and really don't apply to our daily practice.
Okay. Regarding mechanical circulatory support, I think today we learned that a routine use of a mechanical circulatory device for complex PCI may not show any benefit, and in fact may harm also. So it should be carefully selected, and those patients who are extremely high risk, as we discussed, and for the evidence for the indication of cardiogenic shock, it is necessary, but that is not discussed today. For protected PCI, we still don't strong evidence for routinely for all complex PCIs.
And also, if you take good care of access-sized assessment and care, you decrease your complication rates. That also came. Yep.
Yeah. And finally, the drug-coated balloons, where do we stand of the SELUTION DeNovo trial?
I think Dejan should say that.
Yeah. So you know what? I was at a meeting. Maybe I can finish on a lighter note. I was at a meeting in a Central European country, and I asked them, so what do you think? What's going to happen now with the DCB? And they tell me the following. Look, if you look at the number of stents implanted, and that's a Central European country. If you look at the number of stents implanted, they do not go down.
Yeah.
They stay roughly the same. And then I ask, okay, but what happens with the DCBs? Well, they rise, they increase. So how can it be that we stay on the same level with stents while DCBs are increasing? And I think that's the answer. We are using them both. Yep. We are not replacing, we are just using them both. And I think that's a non-scientific, but very quantitative answer to this question, where we are today. Where do we stand after the SELUTION DeNovo trial today? We'll see what the future holds, but this is where we are today.
Yeah, hybrid strategy is increasing, certainly in more and more complex cases where we sort of find DCB making our lives simpler in many of our complex cases through hybrid strategies. Anyway, I think that's really been a great session. This has been wonderful. It's also been educational for all of us as we presented this data and analyzed it and tried to put it into our clinical practice. And clearly the summation just happened with the question Deja asked us all. We really summarized this session extremely well. And I hope you all out there across India and across the world benefited from this interaction, this discussion through the PCR webinars, an outstanding forum of interaction with the experts across the world on current topics of importance as we actually put these practical points into our PCI practice. So be there, watch, thank Dejan, thanks Dr. Sengottuvelu, and I certainly thank PCR for this opportunity, and let's just get together again for another great session.
Thank you very much.
In the near future.
It was great. Thank you very much.
Thanks. Bye. Take care.
Thank you.
Thank you very much.